Welcome to the deep dive. Today, we're looking at something maybe you thought was, I don't know, a thing of the past. Tuberculosis. But here's a fact that might surprise you. TB is still the world's single biggest killer when it comes to infectious agents.
It's pretty staggering, actually.
Yeah, and get this. Maybe a third of everyone on the planet is infected with the bacterium, Mycobacterium tuberculosis. And we see about 10 million new active cases pop up globally every single year.
That's right, 10 million.
So yeah, it's definitely not just history. It's a current, really complex global challenge. Our mission today is to unpack TB for you. Not just the basics, but some of the surprising stuff. How it spreads, how it can show up differently in the body, and how doctors figure it out and treat it. Especially that really key difference between having a silent latent infection versus the active disease. We've dug into some top medical sources to give you the clear picture.
And it's so important to understand those differences because TB can be, well, pretty sneaky. You've got potentially billions carrying it without knowing. So understanding its different forms, how it progresses, that's critical for actually controlling it. There are nuances here that really matter.
Okay, let's unpack it then. So tuberculosis, TB, what is it fundamentally?
Well, fundamentally, it's an infection caused by that bacterium, Mycobacterium tuberculosis.
Right.
We often think lungs, and that's common, but it can actually hit almost any organ.
And this bacterium is called an acid-fast bacillus. Sounds tough.
It is tough. That refers to its cell wall, basically. It makes it hard to stain in the lab, but also really resilient, hard to kill.
Okay, so how does this resilient bug get around?
Mostly through the air. When someone with active pulmonary TB coughs or sneezes or even just talks, they release these tiny little droplets containing the bacteria.
Ah, okay. So you breathe them in.
Exactly. But here's a key thing. It's usually not just walking past someone. It's typically about prolonged exposure, spending significant time in the same space.
Right, prolonged exposure. So that explains the risk factors.
Precisely. Close contact is number one. Think living with someone who has active TB. Also, coming from parts of the world where TB is much more common, highly endemic regions.
Makes sense.
And then crowded settings are a big one. Prisons, homeless shelters, places where people are in close quarters for extended periods.
And certain jobs, too, you mentioned.
Yeah, healthcare workers, obviously, lab personnel working with samples, anyone with repeated exposure potential. But what's fascinating here and really critical is the impact of immunosuppression.
So a weakened immune system.
Massively increases risk. Things like HIV, uncontrolled diabetes mellitus, even medications that deliberately suppress the immune system, like TNF inhibitors used for autoimmune diseases. They basically lower the body's guard, making it much easier for TB to establish itself and become active disease.
Okay, so the bacteria gets inhaled, lands in the lungs, in those little air sacs, the alveoli. What happens then?
Well, your immune cells, macrophages, usually try to engulf invaders, right? They engulf the MTB. But MTD is clever. It can actually survive inside those macrophages, sometimes even use them to travel elsewhere in the body.
Like a Trojan horse?
Kind of, yeah. And from that point, there are basically 4 possible paths the infection can take.
4.
One, rarely your immune system just clears it out completely. Gone.
That'd be nice.
It would, but it's rare. 2, it can progress rapidly into what we call primary active disease. This happens more if the immune system is weak. 3, and this is the most common for healthy immune systems, it goes into a latent phase. You're infected, the bug's there, but it's walled off, dormant, you're not sick, and crucially, you're not infectious to others.
Okay, latent. Got it. And number 4?
Number 4 is reactivation. That latent infection wakes up, sometimes years or even decades later, and becomes active secondary TB.
Wow. So what determines which path it takes?
It's complex. Your individual immune health is huge. Genetics likely plays a role, and whether it's your first time being exposed or re-exposure.
And you mentioned the body sort of walls off the bacteria in that latent phase?
Exactly. This leads to something really characteristic of TB pathology. Caseating granulomas.
Caseating granulomas. Okay, what are those?
So your immune system triggers this specific kind of delayed reaction, a cell-mediated response. Immune cells surround the MTB, trying to contain it. They form these microscopic structures, granulomas, and in TB, the center often breaks down into this cheesy-looking necrotic material. That's the caseating part.
Cheesy. Okay, so that's a key sign doctors look for.
It's a hallmark, yeah. Not only seen in TB, but very characteristic. It's the body trying to contain the infection.
Right. So let's talk about these different forms then. You mentioned primary infection first.
Yeah, primary TB, that's the initial infection event. It usually shows up as a localized spot in the lungs, often in the middle or lower parts. There's a classic term for it, the Goen focus.
Gone focus. Okay. And you said most people control this.
In about 90% of people with healthy immune systems, yes, they control it, and it either gets cleared or more often enters that latent phase, latent tuberculosis infection or LTBI.
And that's the huge number, the billions of people.
That's the estimate, yes. 2 to 3 billion people worldwide with LTBI. They are infected, they test positive on a screening test, but they have no symptoms, no active disease on a chest x-ray, and they cannot spread it.
But not everyone controls it initially.
Right. About 10% of people with primary infection, especially those risk groups we talked about, immunocompromised, HIV, really young kids, older adults, people with kidney disease or poorly controlled diabetes, they can develop active disease right away. That's primary progressive TB.
Okay. And then there's the other main form, secondary or reactivation TB.
Exactly. This happens in maybe 5 to 15% of people who have latent TB at some point in their lives. Dormant bacteria reactivate.
Wakes up after potentially years.
Decades even. It's quite amazing. And secondary TB typically shows up in a different part of the lung. The apice is the very top.
What?
Higher oxygen levels up there. MTB seems to like that environment for reactivation.
Interesting. So mostly reactivation, but sometimes a new infection.
Yeah, most secondary TB is reactivation of that old latent infection, but a smaller number of cases might be from getting infected again later in life.
Okay, so let's shift to what someone actually experiences if they have active pulmonary TB. What are the signs?
It can be quite subtle at first. A prolonged fever is actually really common, often low grade, maybe worse in the evenings.
Okay, a persistent fever.
Yeah, and a cough, it might start mild, non-productive, but then it hangs around for more than 2-3 weeks and often becomes productive, meaning you're coughing up sputum.
Right. What else?
Chest pain can happen, shortness of breath or dyspnea, sometimes coughing up blood, hemoptysis, and then more general symptoms, fatigue, just feeling wiped out, chills. Drenching light sweats are pretty classic too.
Diffuse sweats. Heard about those?
Yeah. And if it's more advanced, you can see significant weight loss, muscle wasting. That's where the old term consumption came from. And just general malaise, feeling unwell. Sometimes swollen lymph nodes too, even with lung TB.
And you mentioned TB isn't just in the lungs. Extrapulmonary TB.
Absolutely. MTB can, in theory, infect any organ.
Any organ. Wow. Like what?
We see it in lymph nodes, especially in the neck, that's called scrofula. It can infect the membranes around the brain and spinal cord, causing TB meningitis.
Serious.
Very. It can infect the vertebrae, the spinal bones, that's pot disease. It can spread widely through the bloodstream, causing miliary TB, which looks like tiny seeds scattered everywhere on imaging.
Miliary, like millet seeds.
Exactly. It can affect the heart lining, pericarditis, the adrenal glands, the kidneys, the urinary tract, really anywhere.
So how does a doctor even begin to figure this out, especially if it's not in the lungs? Physical exam findings might not show much.
That's the challenge. Physical exam can be totally normal in mild pulmonary TB. Or you might hear some crackles or signs of fluid consolidation in the lungs. With extrapulmonary TB, the signs depend entirely on the organ involved. It can be very nonspecific.
So diagnosis must be tricky. How do they confirm it's TB? What's the gold standard?
The absolute gold standard is isolating the organism, Mycobacterium tuberculosis itself, finding it in a sample from the patient.
Like sputum.
Sputum is key for pulmonary TB, or fluid collected during a bronchoscopy, or pleural fluid if there's fluid around the lung, or even a tissue biopsy from an affected organ.
Okay, find the bug. And what about preventing spread while they're figuring this out?
Crucial point. Anyone suspected of having active, potentially infectious TB needs to be put in respiratory isolation immediately, usually a negative pressure room, maybe with special air filters, to stop airborne transmission.
Right, safety first. Okay, so what tools do they use for diagnosis besides finding the bug directly?
Well, imaging is usually the first step. A chest x-ray.
What do they look for on the x-ray?
It depends on the type. For primary TB, maybe consolidation in the middle or lower lung zones. For reactivation TB, you're typically looking for infiltrates, maybe cavities, actual holes in the lung tissue, often in those upper lobes, the apices.
Cavities, wow.
Yeah, and fibrosis, scarring. Miliary TB has that classic pattern of tiny millet seed-like nodules scattered everywhere.
Is CT better?
CT scans are more sensitive, they show more detail, but usually the x-ray is the first look. CT might be used if the x-ray is unclear or they need more information.
Okay, imaging first, Then sputum tests.
Yes, for suspected lung TB, sputum tests are vital. The standard is to collect 3 samples.
3. Why 3?
Increases the chance of finding the bacteria, usually collected at least 8 hours apart, and ideally one is an early morning sample, as bacteria might accumulate overnight.
Got it. What do they do with the sputum?
3 main things. First, an acid-fast stain, or AFB smear. This uses a special stain that MTB picks up because of its unique cell wall. It's quick, it's cheap,
Yeah.
but its sensitivity isn't perfect. Especially in people with HIV, the number of bacteria might be lower, so the smear could be negative even if they have TB.
Okay, so smear's fast, but not foolproof.
What else? Mycobacterial culture. Trying to actually grow the MTB from the sputum. This is the most definitive test for active infection because you prove the live bacteria are there.
Sounds good. Downside.
It's slow. MTB grows very slowly in the lab. It can take weeks to get a result.
Weeks. That's a long time to wait if you suspect TB.
Exactly. Which is why the third test, nucleic acid amplification testing, or NOUT, has been such a big advance.
Yeah, well, it sounds like a DNA test.
Essentially, yeah. It looks for the genetic material of MTB. It's much more sensitive than the smear, and much faster than culture. You can often get a result in 24 to 48 hours.
That's a huge difference.
It is. In many guidelines now, a positive NOUT from sputum is enough to diagnose active pulmonary TB, even if the smear is negative initially.
But a negative NAT doesn't rule it out completely.
Correct. Especially if the clinical suspicion is high, you'd still rely on culture results or other findings.
Okay. And you mentioned histology. Seeing those granulomas.
Right. If a tissue biopsy is done, say from a lymph node or another organ, the pathologist looks for those case-eating granulomas under the microscope. Seeing that pattern is very suggestive of TB, though again, not 100% specific on its own.
And what about those skin tests or blood tests I've heard about? The PPD or quantiferin?
Good question. The tuberculin skin test, TST or PPD, and the interferon gamma release assays, IGRAs, like quantiferon, are screening tests. They tell you if someone has likely been infected with MTB at some point.
Infected, but not necessarily sick.
Exactly. They indicate exposure and immune response. They support a diagnosis of active TB if positive, but they absolutely cannot establish it on their own. A positive screen just means infection could be latent. And importantly, a negative screen doesn't rule out active TB either, especially if someone is very ill or immunocompromised.
Okay, that distinction is really important then. Screening for infection versus diagnosing active disease. Can you elaborate on those screening tests?
Sure. They are fundamentally different tools for different questions. The TST, the skin test.
The one where they inject something in your arm?
Yeah, that's the one. Purified protein derivative, PPD. They inject it, then you come back in 48 to 72 hours, and a healthcare worker measures the diameter of any induration that's a firm, raised swelling.
And the size matters.
Critically, a positive result depends on the size and the person's individual risk factors. For someone highly immunosuppressed or a very close contact of an active case, even a small reaction like 5 millimeters is considered positive.
Okay.
For people with other risk factors, like being from a high-prevalence country or working in healthcare, the cutoff might be 10 millimeters. For someone with no known risk factors, it's 15 millimeters.
So it's not one size fits all.
Not at all. Now, it can have false positives, sometimes from the BCG vaccine, especially if given recently, though that effect wanes, or from infection with related non-tuberculosis mycobacteria.
What about BCG history in general? Does it mean you can't use the skin test?
That's a common misconception. For adults, especially in places like the US, a history of BCG vaccination doesn't really change how we interpret TST results or whether we treat for latent TB if it's positive. We generally screen and treat based on risk regardless of BCG history in adults.
Interesting. Okay, what about the other screening test, the IGRA?
The interferon gamma release assay, this is a blood test. It measures the immune response, specifically interferon gamma release by T cells when blood is exposed to TB-specific antigens.
Advantages.
Its main advantages are better specificity. It's not affected by prior BCG vaccination, which is a big plus. There's no subjective reading of skin reaction size, and you only need one visit for the blood draw, no return visit needed.
Sounds better. Why not always use it?
Well, it's more expensive than the TST. It requires more specialized lab facilities and technical expertise. And like the TST, it tells you about infection, not active disease. There can still be some false positives or negatives, too.
So TST or IGRA, they screen for infection. If someone is positive on either of those, what's the absolute next step?
Chest x-ray, always. For anyone with a positive TST or IGRA, you must get chest imaging to rule out active pulmonary TB disease.
Rule out active disease. Okay.
If the chest x-ray shows findings suspicious for active TB, then you launch into the full diagnostic workup we just discussed, sputum tests, etc.
And if the chest x-ray is clear and they have no symptoms.
Then that's when you diagnose latent tuberculosis infection or LTBI.
Okay, let's nail that down. LTBI. Define it clearly for us.
Sure, LTBI means three things are true. One, the person has a positive screening test, either TST or IGRA, indicating they've been infected. Two, they have absolutely no symptoms of active TB, no cough, fever, night sweats, weight loss. And three, their chest imaging, usually an x-ray, shows no signs suggestive of active TB disease. Maybe old, healed scars, but nothing active.
Infected, no symptoms, clear chest x-ray for active disease. Got it.
Right. It means the immune system has successfully contained the initial infection, walled it off in those granulomas, but the bacteria are still there, just dormant.
And the risk is that it could wake up later.
Exactly, that reactivation risk. Overall lifetime risk is maybe 5 to 10% for someone with LTBI. About half of that risk is concentrated in the first 2 years after initial infection. After that, the risk drops to about 0.1% per year, but it never completely goes away.
A lifelong low-level risk then. So what do you do about LTBI? Is treatment required?
It's actually optional. Management of LTBI is generally offered, not mandated. It's a discussion between the doctor and patient.
Why treat it then if it's optional and they're not sick?
To reduce that future risk of reactivation, treating LTBI effectively can lower the lifetime risk of developing active TB by about 75%, maybe even more. It's preventative.
Okay. And what does treatment involve? Is it like the active TB treatment?
No, it's much simpler and shorter now. The guidelines, especially newer ones from around 2020, really favor shorter regimens based on rifamycin drugs.
Rifamycins. Rifampin.
Exactly. These regimens are preferred because they're highly effective, patients tend to complete the shorter courses more readily, and they generally have less risk of liver toxicity compared to the older, longer options.
What are the options?
The preferred ones are often rifampin daily for 4 months, or a combination of isoniazid and rifampin daily for 3 months, or even isoniazid plus a related drug, rifapentine, taken just once a week for 3 months.
Much shorter than the old way.
Yeah, the older standard was isoniazid by itself, usually taken with vitamin B6 to prevent nerve damage, for 6 or even 9 months. These shorter rifamycin-based options are generally preferred now when possible.
Okay, that makes sense for preventing future problems.
Yes.
Now, just briefly, back to active TB. That does require treatment, right? What's the standard approach?
Oh, absolutely. Active TB needs prompt and full treatment to cure the patient and prevent transmission. The standard is usually a combination of 4 drugs for the first 2 months.
The RIPE regimen.
That's the common acronym, yes. RIPE, rifampin isoniazid, plus pyridoxine, which is vitamin B6, pyrazinamide, and ethambutol. That's the initial intensive phase.
2 months of 4 drugs. Then what?
Then, assuming the bacteria are susceptible to the main drugs, you drop down to 2 drugs, usually rifampin and isoniazid, for another 4 months. So the minimum total duration is typically 6 months.
6 months of multiple antibiotics. That sounds tough.
It is. Adherence is a huge challenge. And each drug has potential side effects we have to monitor. Rifampin turning secretions orange is maybe the least worrisome. Isoniazid can cause liver inflammation or peripheral neuropathy. Ethambutol can affect vision, causing optic neuritis. Pyrazinamide also carries liver risk.
So it's a complex balancing act.
Definitely.
Yeah.
And there are variations, like for pregnant patients where certain drugs are avoided, or if there's drug resistance, which is a whole other major challenge. But that RIPE for 2 months, then RI for 4 months, is the basic backbone for drug-susceptible active pulmonary TB.
Wow. Okay, this has been incredibly thorough. We've gone from this silent infection in potentially billions of people, LTBI, all the way to active disease affecting any organ and the complex ways we diagnose and treat it. It's definitely more intricate than I think most people realize.
It really is. The spectrum is vast.
Hopefully this deep dive has given you, our listener, a much clearer map of this challenging landscape, a shortcut to understanding TB's many faces.
And maybe connecting it to the bigger picture. When you think about that huge reservoir of latent infection globally, billions of people, and the fact that treating that latent infection is often optional, a personal choice. What does that mean for global control efforts? How do we tackle future outbreaks when so many carry the potential? It raises some really big questions for public health strategy worldwide, doesn't it?
It absolutely does. A lot to think about regarding prevention versus treatment on a massive scale.
Well, thank you so much for walking us through all of that complexity with such clarity.
My pleasure. It's a fascinating and important topic.
And thank you, our listener, for joining us on the deep dive. Keep asking questions, keep exploring. We'll talk to you next time.